Now, a very interesting question. I'm going to be talking about all the drugs, the maximum dose that you can give, the contraindications, every single thing in this question. And I'm again going to quote guidelines. I'm not going to be just talking on the basis of what I have read or on my experience. Absolutely not. You all deserve to know what is the guideline. I have shown a picture. I'll be showing it to you when I discuss this question now. So, which of the following antihypertensive drugs is contraindicated in pregnancy due to toxicity? Now, at this point, the answer is very straightforward. But remember that the point of this question is not to teach you which is the contraindicated drug. The point is for you to know what are the other three drugs. Of course, we know that ACE inhibitors and angiotensin receptor blockers are contraindicated in pregnancy. There is no second thought about it. I do know that the answer is going to be my ACE inhibitors, but I have to know what is labetalol. I have to know what is methyl-dopa. I have to know what is nifedipine. All these drugs are very important, and for that, I have again taken the help of my favorite American Heart Association guidelines and yes, American Heart Association guidelines and ACC guidelines as well. So, in pregnancy, if I have to treat hypertension, I have a few very important drugs. What are those few important drugs? The first one is going to be, remember, the first in order is the best drug, that is labetalol. The second best drug, which is nifedipine. The third best drug actually is hydralazine and methyl-dopa, both of them. They both occupy the same place. And hydrochloroside is literally the fourth best. We do not go till there. Over here, I would just add the drug hydralazine, which is, I would say, at par with methyl-dopa. Now, remember that over here, the important point is these are all the oral antihypertensive agents. First, I'm going to be talking about oral. After this, I'm going to be talking about the intravenous antihypertensive agents. So, what is labetalol? Very simple thing. A lot of people get it wrong. Whenever I ask them in the exam, what is the class of drug or mechanism of action, and everyone just says beta blocker. Absolutely wrong answer. It is not a beta blocker. It is non-selective alpha plus beta blocker. Remember, if you talk about just beta blocker, it is metoprolol or metexel, the drug that you may be giving in your wards to your cardiac patients to prevent heart failure. That is a beta blocker. And labetalol is not a pure beta blocker, it is alpha plus beta. The actions of both are very important in this scenario, and it is the best drug. So, what is the bare minimum dose that you started at? A lot of people give doses like 100 mg once a day. Absolutely nonsensical. What is the point of giving a drug that has an action of time of action of only 8 to 12 hours once a day? So you're basically covering half her day with an agent, and the rest of the half of the day you're just leaving it for her body to manage its own hypertension. It doesn't work that way. So the bare minimum dose has to be 200 milligram and 200 milligram in two split doses. That is 100 milligram in the morning and 100 milligram at night. So 100 milligram twice a day makes it 200 milligram. That is the least dose that you have to initiate. There is nothing like 50 milligram twice a day. Do not go into all this. Remember, 100 milligram twice a day, bare minimum. The maximum dose that you can give is 2400. Now, there is a lot of debate on this. A few people say 800, a few people say 600, a few people say 1200. No. Although we do not go to the level of 2400, we start an alternative antihypertensive agent, but the safe dosage can be in pregnancy as high as 2400. Now, in your exams, if anyone is asking you what is your source, just quote these guidelines. Do not forget that. And even here, you can see that they have mentioned that it has to be divided into 2 to 3 divided doses. So that is what is very important they are mentioning over here. It is not to be given as a once a day dosing. It is pointless to give it once a day. So, yeah. So at this point, I have mentioned that your doses, important doses will happen in twice a day or thrice a day regimen, and your maximum dose can be 2400 per day. And what are the possible side effects? Remember that it has potentially bronchoconstrictive effects. So remember that it is a beta blocker as well, alpha and beta. And beta blocker will mean that your bronchospasm is initiated because your beta adrenergic agonists are going to dilate your bronchi, whereas your beta blockers are going to constrict it. which is why in patients with asthma or with patients with pulmonary edema, you have to be very careful while giving it. So if it would have been our first patient that who was having pulmonary edema, in that patient, though the option did say IV labetalol, I would definitely need IV labetalol to, bring her BP down. But before that, I would want to give her diuresis to make sure that her lung fields are cleared out before I give labetalol. So it is said to be a relative contraindication if the patient has any lung disorders. Although pulmonary edema as such is not an issue, asthma is a definite issue, so you have to be very careful. So, what are the patients in which you have to be careful? First of all, asthma, pre-existing myocardial disease, decompensated cardiac function. Why am I saying all this? Because just like your bronchus, it is also going to constrict it is going to constrict a lot of your vessels, and basically it is going to increase your cardiac workload. And of course, given that it can block your signals, heart block is also possible, bradycardia is also possible, and hence in patients with an active heart disease right now, basically heart failure or myocardial infarction, if your patient has had a recent one, you would want to avoid this. Otherwise, it's a very safe drug. It is not a highly potent drug. It is not that great a drug when it comes to the oral formulation. But this is what you need to know about labetalol. Now I come to nifedipine. Nifedipine is a very simple drug, calcium channel blocker. The bare minimum dose that you usually give is they are saying 30 milligram, but then I prefer to give even a 20 milligram dose, basically 10 milligram twice a day. So 20 or 30 milligram you can give, but the maximum dose is very important here. The maximum dose is 120 milligram per day. You cannot exceed 120 milligram. And when I talk about 120 milligram, you can split it in four doses of 30 milligram each. So 30 milligram, four times a day, that is 120 milligram. Do not use the sublingual form. Now we get two forms of nifedipine. There are two forms of nifedipine that are available. One is the instant release and the other one is the sustained release. Remember that this instant release, which looks like an orange egg-like, egg-shaped, a very small egg-shaped, smooth looking capsule. A brand name is Depin. Whenever you consume that instant thing, remember that you do not have to keep it in your mouth. You have to immediately take water and gulp it in. You have to swallow it immediately because if you keep it sublingually, there can be drastic hypotension. Your BP can drop to as low as 80 by 60, 80 by 50, and that will significantly impair your uterine perfusion. Your fetal perfusion is going to be significantly impaired, and that can lead to fetal distress and even fetal demise. And not just that, even the patient can have an syncopal attack or transient ischemic attack, which you do not want. Hence, remember never to use the sublingual form. It is pointless. If you want to bring the BP down drastically, give the IV labet form, but do not give it sublingually. Sublingual is basically do not ask the patient to keep that tablet or capsule in their mouth for a long time. That is it about the instant form. The sustained release form is the one that is actually used for blood pressure control because it has a long action of as long as 8 to 12 hours. And instant release drug has only an action of 4 to 6 hours, but the long acting sustained release has an action of almost 12 hours. So, in fact, it can even go up to 24 hours. That's how long it can work, but definitely for 12 hours. Hence, you have to avoid using the sublingual form, and for hypertensive control, you have to use the sustained release form, which is also, if you know the name as Nicardia. Remember, Nicardia does not contain nicardipine, it contains nifedipine only. It is just nifedipine retard form. That retard is basically delayed release. Hence, Nicardia, that is nifedipine retard. It's a combination of these two words. So, when do you give the immediate release form or the instant release form? It should be only reserved for control of severe, acutely elevated blood pressure in hospitalized patients, but again, not given sublingually. It is only given orally, and you have to immediately swallow it. The next drug that we have happens to be alpha methyl dopa. Now, until 10, 20 years ago, this methyl dopa or alpha methyl dopa was the drug of choice for hypertension in pregnancy, but it had a few side effects, which is why it is no longer even the second line drug. The mechanism of action is alpha 2 agonist, adrenergic agonist. So basically, the work that it does is it causes vasodilatation because of binding to the alpha 2 agonist, alpha 2 adrenergic receptors. Now, at this point of time, the minimum dose that you used to give is going to be 500 milligram and the maximum dose is 3000 milligram in 2 to 4 divided doses. The commonly initiated doses are 250 milligram 2 to 3 times a day. So you give it in the formulation of 250 milligram. And the problem that the reason it was stopped is that it led to a lot of things. First of all, it led to depression, dizziness, and also it led to positive ICT status. Basically, it was triggering autoimmune hemolytic anemia. This was a significant problem, and also it was not that strong a drug for treating hypertension. It was a very weak drug, which is why it fell out of favor in favor of labetalol nowadays. But this was very important problem with methyl dopa. It is no longer used. I have never even myself seen any patient getting methyl dopa anymore. The next drug is going to be hydrochlorothiazide, which is a diuretic. It is hardly used nowadays. We use a diuretic, another diuretic, and that happens to be the high loop diuretic, which is furosemide. And we no longer use hydrochlorothiazide, so not really recommended. The drug that we do use can be hydralazine. It is given in what is the mechanism of action? Or this is a drug of action. Drug that this mechanism of action is not known. It is only known that it inhibits hypoxia inducible factor 1 alpha, जिसके वजह से arteriolar dilatation होता है. It directly acts on the arterioles and it causes the dilatation, and that is going to reduce your blood pressure. It is given in the doses of 5 to 10 milligram 2 to 3 times a day. Again, this is a very strong drug and it can lead to hypotension, which is why it is avoided nowadays. In fact, it has been seen that every time a patient was given hydralazine, her blood pressure would immediately drop for a while. And that was a period when there were changes in the CTG that was seen for that fetus. So there used to be loss of beat to beat variability. There used to be a few decelerations. It had even shown to cause fetal bradycardia, which is why it is not that used, but it will still be the third most important drug in this list that I've spoken about. Now, these were all the oral drugs. What about the IV drugs? So, IV drugs are going to be used for urgent blood pressure control. So in that, again, the first drug is labetalol. In that, you start giving 10 mg first by IV. You have to give it very slowly. You have to be giving it very, very slowly, because if you give it too quickly, that will lead to bradycardia and even heart block can occur. So you have to give it very slowly, and you have to increment in doses of 20 and then 40. The maximum dose that you can give is 300 milligram, not more than that, and the onset of action is within a minute and the total duration of action is around 15 to 20 minutes. So after 15 to 20 minutes, you have to measure the BP again and you may have to give a repeat dose. So you would ask me, what is the point of this drug if it is only going to control for 15-20 minutes? Remember, it is for hypertensive emergency. So hypertensive emergency may the only goal that you have is to immediately bring the blood pressure down. When you are doing this, also give the patient or drugs like Nicardia, that is Nifedipine sustained release, so that once your acute control has been brought about by IV labetalol, the subsequent maintenance control can be brought about by the other oral formulations, which is why this drug is only good for short term. If you want to control, if your patient is unconscious or altered and you cannot take oral drug, then you can also use it as a drip, that is called as constant infusion at 1 to 3 milligram, that is 2 milligram per minute through IV. It is diluted in normal saline and given, so we call it labet drip. You can give it in that form. But the important point over here is 300 milligram is the maximum amount that you can give within 24 hours. The next drug that you have for intravenous, although labetalol is a very sufficient drug, it will in all cases bring your BP down immediately. But if you want to know about other drugs, then you have hydralazine, which is given either intravenously or intramuscularly in the dose of 5 milligram, and then you can augment it up to 10 milligrams every 20 to 30 minutes to a total dose of only 20 milligram. So 20 milligrams is ज़्यादा देना नहीं है. As I've already mentioned that the problem was maternal hypotension, headache, and abnormal fetal heart tracings. As I told you that your CTG will show changes. It would show changes of loss of beat to beat variability, bradycardia, decelerations. All these problems were seen, which is why that was detrimental to the fetus. The hypotension that it caused was detrimental to the fetus. Lastly, nifedipine, I've already mentioned, if you have to give the immediate release form, it has to be swallowed immediately and it will also bring your BP in control within the next 10 minutes. But the fastest blood pressure control is going to be by labetalol, which is within 1 to 2 minutes. So these are all the antihypertensive drugs that you need to know about the oral and the intravenous formulations. I hope this point of which drug, when, in whom to not give, and what is the maximum dose, all of this has been cleared for you all. So the answer over here is very obviously the answer is going to be ACE inhibitors because, of course, ACE inhibitors are contraindicated. It leads to renal artery stenosis, renal agenesis in the fetus. You do not want that, and hence you would preferably avoid it. Whereas the other drugs are the drugs that are indicated in pregnancy. Which guidelines have I used? Again, your ACOG and NICE guidelines have been used for this formulation of this question. I hope everyone is clear with their concepts. If anyone has any doubt, please let me know in the chat. I have been very explicit with each and every guideline until this point. If there is any doubt, do not hesitate to ask me. Remember that this video and several other videos in this segment are available exclusively for subscribers on our Conceptual OBG app. We have an ongoing offer as well right now, which you will find if you go and just search through our app for the premium offers. If you have any doubt, contact me directly or contact, I will give you a couple of contact numbers who you can contact with regards to the offers and everything. Go ahead and check this out. Any doubts, please let me know in the chat. I'll be answering them. If not, this is it from Dr. Aditya. We have a total of over 50 to 60 such sessions that we have planned, that we have lined up for your entrance preparation. And of course, the books, the online questions, everything. It's a huge question bank, and that is in addition to our core OBGY subjects that we already have, the session, the lectures that we already have. All of this only for your premium subscribers, only exclusively for premium subscribers. So do look at the plans and do subscribe. This is Dr. Aditya signing off from Conceptual OBG for tonight. I'll see you again next week in yet another session. Until then, this is Dr. Aditya taking a leave. Good night.